Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are key words or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAHDO's Director of Projects. Charles, the stage is yours.
Hi, everyone. Thank you for being here. It's a pleasure to be with you. This session, Advanced Analytics, Applications for Uncovering Spending Variation, Climate Impacts, and Health Disparities, was organized by Mary Fields, who will also be today's moderator. And this session is sponsored by Comagine Health. We'd like to give a big shout out and special thanks to all our friends at Comagine for their generous support as sponsors. And let me bring Mary on stage. Hi, Mary.
Hi, Charles. Thank you for that introduction.
The floor
Good
is yours.
afternoon, good morning, as the case may be, everyone. I'm excited for this next panel. And up first, we have Chris Frenier and Daniel Kurowski from Healthcare Cost Institute. And they'll be talking to us today about communicating healthcare prices with service bundles. With that, I'll turn it over to you.
Hello, and welcome to Communicating Healthcare Prices with Service Bundles. Today, I'll walk you through how to use HCCI's Health Prices Toolkits and our website, healthprices.org, to measure and communicate healthcare prices in ways that are meaningful to patients and policymakers. A brief outline for today's talk is that first I'll introduce our Health Prices Toolkits and briefly describe the methodology that underpins this work. I'll show an example of a simple and complex service bundle and how we build that up from individual services. And then I'll highlight our tools for comparing prices on healthprices.org before giving everyone a brief preview of some of the continuing development we're doing on these tools. To get started, we first need to talk about what we mean by a healthcare price. And defining that isn't always so simple. When it comes to healthcare, are we talking about a particular type of facility, different types of providers or drugs? And thinking about a service, is this one simple CPT code or discrete service or an entire episode of care? And there's even some confusion about what we mean by price. Are we talking about the entire billed amount from the provider, maybe the allowed amount that combines the patient and insurer responsibilities, or even just the out-of-pocket amount? The goal of Health Prices Toolkits is to bridge the gap between these technical definitions and how patients experience care. The goal of the Health Prices Toolkits is to group services into intuitive bundles that reflect how patients actually experience healthcare. The bundles focus on shoppable services, which are things that patients can plan for or compare prices between different providers. When we measure prices, we use the allowed amount, which includes both the patient and insurer components of the cost, which allows us to compare prices for different steps and for the bundles as a whole. Bundles form the core of the Health Prices Toolkits. Each bundle includes one or more steps, and each step can include one or more services. We define the services using claims data and then build those services up to a step and a bundle price. And that structure helps us estimate total costs for specific types or episodes of care. We can see this structure in our sleep apnea bundle. So the overall bundle includes 3 different steps: diagnosis and evaluation, a sleep study, and then treatment. And each of those different steps is comprised of one or more services, which range from office visits to the fees for a CPAP machine, or perhaps even the accessories that go with that CPAP machine. When we estimate bundle prices, we actually work backwards from the service level. So we start by getting the individual price of a service using claims data, looking at allowed amounts. We then calculate the average price for that service across all providers in a given geographic area, such as a CABSA or a state. That gives us a service price, which we can then sum together into a step price, and all of the step prices sum together into a bundle price. We measure prices using two data sources. The first is HCCI's commercial claims database, which includes data from employer-sponsored insurance plans. We also measure the same prices in Medicare fee-for-service claims. Using two different data sets gives us a broad view across age groups and payer types, and also allows us to compare prices in public and private insurance. Next, I'll show two examples of some service bundles on healthprices.org. The first one will be a simple one-step bundle for preventive mammography, and then I'll show a more complex bundle after that. The preventive screening mammography bundle is a one-step bundle with a nationwide average price of $393, a 25th percentile price of $286, and a 75th percentile price of $549. When we expand that bundle, we see that it's made up of a single step and that step has three services included. There's two professional imaging codes, and then there's a facility fee. And here we note, as is often the case when we examine these, that the facility fee makes up the majority of the cost, 73% in this case. Turning to a more complex example to highlight the difference between bundles, steps, and services, we'll next look at inpatient hip replacement. Overall, this bundle has an average price of about $34,000, a 25th percentile price of $25,000, and a 75th percentile price of about $43,000. We can see that the hip replacement bundle includes four steps: an evaluation of symptoms, the actual surgery to conduct the hip replacement, post-op exercise consultations, and then some follow-up imaging. And you can see the average 25th percentile and 75th percentile of those different steps displayed on the table. Zooming in on the surgery step, because that was the most expensive step in the bundle, we can see it's actually comprised of several different services. We have an anesthesia fee, physician fees for both the surgeon and for care in the hospital, and a hospital facility fee, which again, for the inpatient hip replacement, is the majority of the bundle cost. Over $30,000 was due to the facility fee. So these types of visualizations can help patients understand where costs are coming from and what types of questions they might want to ask their provider when they're shopping for services. The data that I've been sharing are all published on our website, healthprices.org. On healthprices.org, we have a price comparison tool where users can compare bundle prices across states or metro areas, and also do these deeper dives into the step and service prices within a geographic area. Another cool feature is that you can compare prices between Medicare and commercial insurance on most of the bundles. This slide is a screen cap of healthprices.org. It's showing the price comparison tool for the preventive screening mammography. And you can see here, first we display a map where we've color-coded higher cost metro areas to be the darker blue, and also a useful histogram showing where the national average price is and sort of that distribution of prices that a patient might be interested in. And you can see also the note here that the private insurance price for this procedure was $211 higher than the Medicare price. If users click on a metro area, such as Minneapolis, where I'm sitting right now, the tool will zoom in on that area and report its price, so $487. That's higher than the national average price, but still sort of in the center mass of the histogram. And you can see that in Minneapolis, the screening mammography is $301 more expensive in private insurance than it is in Medicare. So moving forward into the future of health prices toolkits, we're continuing to add enhancements and features to try to improve functionality and give people more options with this tool. So right now, one thing we're excited about working on is maybe adding in the ability to do provider level comparisons within a geography so that you can see which providers are more or less expensive. We're also always interested in adding new or updated bundles as new types of care become of interest to patients and policymakers. And in the longer term, we'd be interested in adding some stratifications by age, sex, and patient complexity, since those are obviously factors that can affect the service intensity and the price of bundles. We're very excited to share with attendees of NAHDO that in 2026, we plan to launch the Health Prices Toolkits as a licensable product that health data organizations can use in their own databases. The tool that we plan to release will include documentation and guides for how to calculate service prices and bundles. It'll have code files to help do some of this grouping in your data for you, and also include data files of the benchmark data so that you can compare your results to the results from the HCCI database. The goal of all of this is to help data organizations measure and communicate health prices in a way that's transparent, replicable, and easy for consumers to understand. So in conclusion, I want to thank everyone here for joining me, and I hope that this presentation sparked some ideas for how your organization could use health prices toolkits. And my colleague Daniel and I are really looking forward to your questions and the discussion to follow. Thank you very much.
Thank you so much for that, Chris. It was a great presentation. We have something similar that we do here in New Hampshire for Health Cost website, but it's specific to New Hampshire. Can imagine a lot of people in the audience are wondering how you got there from here and all those kind of things. So I don't know if there's questions from them, but first, could you maybe give us an idea of how this approach is maybe different from current episode groupers or other similar approaches?
Sure. Yeah. Thank you for the question, Mary. I think one of the things that we like about this approach is honestly its relative simplicity. So I think there are lots of different ways to calculate the costs of a bundle or a service episode. You know, you can sort of look for index dates or index events and take all spending over a certain period, or look at specific code level detail. We actually sort of got input on what, and both on the empirical side from data and also sort of clinical input on what types of codes, CPT codes, revenue codes, would sort of constitute a representative bundle for each service. And so rather than the cost being a function of sort of patient severity or mix or things like that, we're really just taking the average prices of discrete codes in our data and then sort of adding them up in a way that we think makes sort of intuitive sense. So in the background, you know, it's nice. It operates as kind of like one really big lookup file where every one of these bundles and steps is associated with a certain number of codes. And so that makes it pretty portable to different data sets, I think.
Yeah, and I think what I got from your presentation, well, I mentioned New Hampshire's health cost. We look at it service level only. And when I think of groupers, I think of them from somebody who has to understand what you're looking at first. And I do appreciate the way that you've presented it being from the patient perspective. I think that it's much more understandable with the way that you've put it out there. So could this methodology be used to apply to transparency and coverage, like machine readable files?
Yeah, maybe let Daniel jump in and chat about that, since he's sort of our expert on this.
Yeah, no, definitely. I mean, in fact, they were designed with tick files in mind as those regulations were coming out a few years ago. One of the first questions we were getting was, can you guys look at the shoppable services? And the first 300, the first 500 services. And as we were looking at the data and the methodologies we employed here at HCCI, we were able to really quickly sort of pivot and address how the data was going to come in the machine readable files. There are a couple of limitations, and that is some of our data includes and is specific to modifiers on the CPT code, and to the extent that they're not available in the MRFs, and that is with, like, Chris gave the example of sleep apnea, and it is specific to whether you're renting the equipment or buying it. And so if that's not in the MRF file, then you need to code around for that.
Fair. Are there any questions from the audience right now specific to this? Great. So Julie Sonnier has asked, on the national map you displayed, there was a lot of white space. Does that represent gaps in the data available or something else?
Yeah, it's a great question, Julie. Thank you. You're exactly right. Those are form-based statistical areas on that map where we, in our commercial claims data, which is the visualization in the screen cap, where we don't have enough providers or claims to sort of get a stable estimate. So, you know, we don't want to just report the prices of like one or two providers in a region that's not representative of the market as a whole. And B, you know, I should highlight that our commercial claims data is about 33% of the employer-sponsored insurance market nationwide. That varies a lot from CBSA to CBSA. And so that is a limitation of sort of the commercial side, is that we don't have that full commercial claims data, which I know a lot of us wish that somebody would have the full picture nationally, but that doesn't exist, unfortunately.
Such is our life, right?
Right.
So we have another question here from Gloria. She has asked, is it still the case that Anthem and United Healthcare claims data are not an HCCI as they are the dominant payers in our market?
Daniel, do you want to jump in on this one?
Yeah, correct. The data set that we're currently employing doesn't have those pairs.
Okay, thank you. It's a quick answer. We have another question, and I apologize. Lan has asked, great presentation. Could you please explain what is the core-based statistical areas? Also, for inpatient bundle of care, could that include multiple inpatient stays? Say a patient get discharged and then they're readmitted. If so, what's the time frame to decide whether those inpatients should be bundled into an episode of care? Which is a great question.
Another really good question. Yeah, so I'll take sort of the geography question first. So a core-based statistical area, that's a census definition. You can sort of think of it as a metro area. So for example, like I'm in Minneapolis, and so our CBSA is the Minneapolis, St. Paul, Bloomington, Roseville. It sort of includes all the major suburbs that abut right against it. So I think we like the CBSAs because they do sort of represent that, St. Paul is another city, but I can easily cross the river in 10 minutes and go to a hospital in St. Paul if I want to get care there. So we think it's a nice proxy for the whole market in a region. And on the inpatient stays question, we're using sort of DRG level coding to estimate the inpatient costs. And so this would just be for a single stay, typically. Readmissions are definitely a big factor in prices or in total costs, and whether there's a readmission or not can really swing those. And we're sort of taking the stance that we're looking at a single admission, not it and its subsequent potential readmissions.
Okay. Well, I think that kind of wraps up what we have time for before our next presentation, but I'm sure we're going to have more when we all come back on stage. So with that, thank you. And I would like next to invite and introduce Rong Yi from Milliman, who is going to go over understanding the impact of climate events on health. Take it away, Rong.
Hello, everyone. I'm Rong Yi. I lead Milliman's data science modeling practice. I've worked in healthcare analytics for 25 years and only started working on climate health topics since about 3 years ago. Today, I'll share with you how we've modeled the associations between climate events and health and discuss how payers, providers, and APCD stewards could move from data to action. A quick disclaimer, this is purely informational, not advice. Views are my own and not necessarily Milliman's. There are two threads I'll be discussing today. First, what data, how to let the data talk, and what the data says on the topic of climate health. The second, what actions organizations can implement and what role the APCDs can play. Here are the long-term heat waves and wildfire indicators from the EPA. On the left side, we're looking at the bar charts showing that heat waves are more frequent and longer. On the right side, the trend lines are showing wildfires as burning for longer periods of time and larger areas. As individuals, we have all experienced heat waves and bad air. How does it impact healthcare, and how can we see this from claims? So in the past several years, we've completed research to quantify the associations between climate events and healthcare utilization and morbidity. So here I'm highlighting a few that's been published, including the most recent one, sponsored by the Society of Actuaries. All of these are looking at longitudinal claims and merged with daily temperature data, relative humidity data, and air pollution. And as you can see, because this is very complicated, we drew from within Milliman many different areas of expertise, such as, in addition to health economics, environmental sciences, GIS, data science, clinical, and insurance design and policy experts. Across these studies, we find that there's some common patterns. Climate events that we study, especially extreme heat and poor air quality, they're statistically significantly associated with utilization and morbidity. The most interesting pattern we found initially was that the effect runs in both directions, meaning during extreme heat or bad air quality, some people reduced healthcare utilizations while others had higher utilizations. When we layered SDOH data on top of that, the patterns started to emerge. So holding age, gender, and morbidity constant, individuals residing in lower socioeconomic communities tend to be more negatively affected. So in other words, socioeconomic factors work very much like an amplifier on climate's impact on health. We also found that extreme heat and air pollution contribute to mental health, especially in the Medicaid populations. We found that there were immediate surges. For example, when it was bad air quality, there are more asthmas and COPD-related visits. And there are also lasting effects. In all of the studies, we found that the impact from heat or pollution could last for 2 years, perhaps even more. So what data? Here's a data framework we established, which I think can be standardized across the industry. In a nutshell, we created a multitude view. Claims carry date information and geographic identifiers. And then we joined the claims to daily heat indices and air quality measures. And then we overlay the geographically coded SDOH data and healthcare facility and health systems data. So they're all, because everything, the common denominator is that everything is geographically coded. So this fusion allowed us to look at the climate health relationship in a multi-angle view. It sounded simple, but the data fusion actually took quite a few different expertise. So climate scientists, GIS modeling, provider data, and so on. Everything needs to connect tightly, and that is the harder part. How do we let the data talk? This is done through modeling and discoveries. So how have we approached this? We think that, an analogy would be like thinking of modeling like drawing a tree. On the left side, you see the classical statistical view, which is that you draw the tree trunk and then you draw a kind of dome-shaped crown. It's explainable, it's beautiful, and it gives you a rough sense of what's going on, but it's also a shallower learning. So on the other hand, on the right side, machine learning actually is a lot more sophisticated. It actually can be used to describe a fuller branching canopy. It's great for discovering thresholds and interactions of different factors. But of course, the downside is that it's often harder to interpret. So our approach has been, we want to combine the best of both worlds, which is that we would do data discoveries with the detailed tree, meaning machine learning, and then we summarize back to the simpler, more explainable shape so that it would inform operations and policy. There's some recent industry activities on climate and health. The payer-led work, so for example, Blue Shield of California has been a pioneer in this field. We collaborated with them on that extreme heat and air pollution paper that came out a year ago. And there's also a broader industry coalition. So this is the Health Insurance Working Group on Climate. Quite a few very large national and regional health plans are participating. This is about sharing knowledge and standardizing measures so that they can report and compare and contrast amongst themselves. And there are actual studies, and the primary leader in this field is the Society of Actuaries Research Institute. There's been quite a few climate-related studies of programs developed by the SOA. And then health systems, pharmaceutical industry also are very active in this field. I only highlighted a few, but they're into different things. In addition to trying to reduce the climate impact, they're also looking at how they can change the way they deliver medicines so that it's lowering low-value care, but also having a positive environmental impact. Some of them are also tying their efforts to resilient cities. And then there are multi-stakeholder initiatives the prime example is the New York City Climate Week, which happened usually in concurrent with the UN General Assembly. It was last month. And also a new initiative called the Health in Climate Hackathon. The first ever took place last month, and Milliman was honored to be a data contributor, a sponsor, and I got to be an advisor, and a colleague of mine also was a judge on the hackathon. It was a way to put our heads together, try to use data to solve some tough problems using in a prototyping way. And there are also regulatory initiatives. So how can APCDs help to power the climate health intelligence? As you can see by now, every one of these efforts needs comparable longitudinal data and common metrics. APCD actually could become the backbone of such efforts. Exposure to outcome measurements, equity stratification, program evaluation, informing the next round of action to be more evidence-based and scalable. So specifically, APCD could be providing the linked data. So this is where claims, climate data, SDOH, infrastructure data can all be merged together. And APCDs could be leveraged to provide early warnings and developing search playbooks. So this is where the unique aspect of APCD is that you have all members, you have all healthcare systems represented in your state's data. It makes actionability a lot more meaningful. And finally, there's the public insight that you can provide, that you can help with guiding local planning. I want to end the presentation with this, the three different charts representing the universe or the stars. So how do we see the unseen? APCDs or claims data plus everything else, the better lens, the better way to fish for data and wait longer. And this is where patterns would emerge. And this is where our understanding of the issues are also deeper. So I want to end with a thank you to NAHDO for giving me the opportunity to present.
Thank you, Rong. That was a great presentation and an incredible way to present how powerful data can be and what it can mean to more than just healthcare cost. It can matter to everybody, right? It makes us more valid, if you will. So I'm sure there's a million questions coming in from the audience, but I will say first, could you say how APCDs contribute to climate and health preparedness?
I think, again, going back to one of my last slides, so we have, say, de-identified research data that probably anyone also have access to, but they're all de-identified. We could use those data to establish projections, but the actionability still would have to come down to which geography, what health systems, which patients. So this is where I think the unique features of an APCD, because it's a state-based, identifiable potentially to the policyholders, or not policyholders, to the regulators and the entire healthcare community locally. This is where I think it's uniquely positioned. Now, in terms of preparedness, well, there's probably more than one. There's the resilience building, which is identifying locations or subpopulations where the climate events, extreme climate events, are likely to have a worse outcome. It doesn't require someone like me, who knows how to do the modeling to really figure it out. So this is probably your seaboard or your lower socioeconomic areas where there aren't really a lot of protection against heat or air pollution, or even not heat, extreme temperature rather. So I think that those are the communities I think people are already very familiar with. And the next thing is to think about the impact in a longitudinal way, which is it's not one-time events. So not only that these extreme climate events are recurring more frequently, but also that for each episode, it will have a lasting impact. So in one of the studies, we saw that bad air usually hit faster. So in other words, you would expect a surge in respiratory conditions during an episode of wildfire. But then the impact of extreme heat usually takes a few more weeks to kick in. So this is where the circulatory conditions will start to emerge. And then, as I mentioned, we observed the impact of climate events on mental health. This is still quite of a, I'm not sure, a shocker. So I think I don't really, I'm an economist, I don't quite understand the physiology, but we're seeing this in the data. So now in terms of how exactly that the demand for mental health can be serviced during or after for months forward. So that it actually is also a challenge that maybe ABCD data can actually shed some light on.
It's fascinating. I mean, as much as we all think we're in touch with, all the things that are happening on our planet and into our neighbors and we're even ourselves sometimes, thinking about how it all connects and how we connect with one another to make sure that, we can get ahead of it or we know what to do when it happens, having a plan of attack. It's critical thinking that I think needs to be taken forward. Are there additional steps in mind for your research to...
Yeah, absolutely. Well, I think what we've done is we've built an analytic framework, a methodological framework to study such impacts. So I guess, the question is always, how do we move from data to action? So what can the insurance industry do to address the emerging risks? What can providers do? What can communities do, or payers, to that matter? So I think as I mentioned, there are insurance or health plans actions. So we're looking at not just in the U.S., but probably less in the U.S., but more internationally, especially in Europe. There are the insurers usually outside of the U.S. Covering different lines of business. So you would have life together with health, or life, health, and property and casualty. This is where, for a very large organization, they're concerned about the exposure in a much bigger way. I think in the U.S. we're seeing actuaries starting to think about, should their pricing be different? Should their provider network design be different? Not different, but to have a more strategic understanding of what the risks might be. I know that it would be very challenging to make an investment as one entity, because climate risks are not something that one entity could actually make a difference, but it's more about the collective community awareness and community, all of us, all stakeholder awareness and preparedness.
That's great. Again, very innovative. Thank you very much, Rong. I don't see any questions currently coming. I know you're all thinking really hard. I would encourage you to think of some more. I'm going to go ahead and move forward with our final presenters. Next, we have Kimi, Landry, and Valerie Garrison. They are with our lovely Civic, and they're going to talk to us today about communicating. I'm sorry, I apologize. They're going to talk to us about evaluating health disparities among American Indian and Alaskan Native populations in Colorado. And I will, at that point, give it over to Kimi and Valerie. Thank you.
Hello, everyone. Thank you so much for joining me today. My name is Kimi Landry, and I'm from the Center for Improving Value in Healthcare, or CIVIC. I'm sure many of you have seen us before at this conference and many other times. But today I'm really happy to share what we've learned from a project we completed with the Denver Indian Center, where we were looking at health patterns among American Indian and Alaskan Native residents in Colorado. This analysis used 10 years of data from the Colorado All Payers Claims database. So, why does this work matter? We know that Native American communities in Colorado continue to face big, long-standing gaps in health and access to care. Emergency room visits are still high, but follow-up care, those crucial next steps after someone leaves the hospital, happens less than 5% of the time. That number has barely changed in pretty much a decade. So behind those numbers, though, are real people, families managing chronic illness, likely traveling long distances for care, and often navigating systems that weren't built for their realities in mind. So this project was really about using data we do have to see those stories more clearly and hopefully start to close the gaps in health outcomes. So for our data and methods, we looked at 10 years of COAPCD information from 2014 through 2024. To add context, we linked it with population data from the American Community Survey and used what we call Z codes, which are basically billing codes that describe social or environmental stressors like housing or employment challenges. And altogether, that gave us a picture of about 5.6 million Coloradans. And we really focused on comparing American Indian, Alaskan Native populations to non-Hispanic, white, and unknown race groups. So our first takeaway was around preventative care. You'll see from this slide that American Indian, Alaska Native residents had fewer preventive visits and screenings documented, but higher rates of chronic illnesses, things like diabetes and thyroid disorders. This to me really suggests, and to Denver Indian Center, that people are reaching care later when problems have already progressed. We also saw fewer recorded mental health diagnoses. Again, that doesn't mean less need. It's more likely underdiagnosed, possible stigma happening, or simply that mental health care often happens in settings that don't bill through insurance and therefore don't appear in these data. So next we looked at how care is being used. Hospital stays declined by about 10% over the decade, which could mean better access to outpatient care, but emergency visits stayed high. And when people did go to the hospital or ER, we saw that very few had follow-up appointments afterward. That's where claims data can be very revealing, and I think are very revealing here. We can literally see the start of an encounter, but often the continuity of care that should follow is not being seen here. So when we turned or looked at costs, we found that spending for American Indian and Alaskan Native residents averaged around $1,000 per person per month, and higher for those covered by Medicaid. Commercially insured members spent less overall, excuse me, but their patterns were still different from other racial and ethnic groups. And really the key takeaway here isn't about dollar amounts. It's about cost and coverage. It's about how cost and coverage don't automatically translate into what seems to be equitable access or outcomes. Geography tells also another important part of the story. As you can see from this slide and this map, most care happens in Denver and Aurora, often through safety net systems like Denver Health. Pueblo saw declines, while I apologize, I am not great at pronouncing this. near the Ute Mountain Ute tribe saw increases. And then that pattern reinforces what community patterns have been saying for years. And what the Denver Indian Center really helped reinforce for us is that people go where they feel welcome and where relationships with providers already exist. So finally, we explored social risk data. We can see from this slide that housing instability, family strain, and work challenges through Z codes. But we know that this often underrepresents reality. Z codes are very limiting in terms of billing and administrative structure. When we compared it to census data, it was clear that claims only show a small slice of what people are actually experiencing. And one of the biggest lessons from this project, even our best data sets still miss a lot of lived experiences. So combining them is really important. Claims are great for showing where care happens, but not necessarily why it happens or what's missing in between. So some implications and next steps. First, we have to keep improving how race and ethnicity are collected in administrative data. That is foundational. Second, we need to help providers and systems understand the importance of culturally grounded care, not just more care. And third, we need to keep working directly with Native American and Alaska Native-led organizations. So analyses and evaluations like this are guided by community priorities, not just research questions. At Civic, our role is to make sure data is used as a bridge, something that connects systems to the people they're meant to serve. These are some references to today's presentation. And then, thank you for listening. And I want to give a special thanks to our partners at the Denver Indian Center and to the communities whose data and experiences made this work really possible. So thank you again for joining me and listening to my presentation, and looking forward to taking questions. Thank you.
Thank you, Kimi. That was a great presentation. It's a whole new way to look at things. And Val's joined us as well. I hope you are able to, you're great. You can hear everything. So we have a bunch of questions coming in from the audience, but I'm going to be greedy. I'm going to ask you a question or two first. When you mentioned ER visits and follow-ups, and I think this might be a question that I end up asking again when we all join, because you're not the only ones that talked about that. Are you looking at the severity or the type of ER visit versus the follow-ups?
That is a great question. No, we did not take it that far. Honestly, that would be a really great comparison to make, to see, how sick people are entering an ER and if they're doing that follow-up rate, exactly. I think that's a great question, but we unfortunately did not have the opportunity or the funding to quite take it that far.
More digging to happen, right?
Yes.
All right. So I do see a bunch of questions coming in. Let's see who we start with. We have, there's quite a few questions. It's popular. Anya Tova asked, what was the time span you used for follow-up appointments?
So our follow-up care is always measured in 7-day follow-up rate. So we do essentially, we measure if a provider visit was happened within 7 days. So that's our quality of care indicator.
Yeah, great. And her follow-up question is that why you used a 7-year data span?
We tried to use as much data as possible. So our analysis, it didn't get to quite show it in the short presentation and the time we had, but our analysis actually was split into 2 time periods. So we did 2014 to 2024 years, and we found that a lot of the reporting and administrative claims data in the earlier years, 2014 to 2017 specifically, they had very different enrollment sort of numbers in terms of the American Indian Alaska Native reporting. So we split our analyses into 2 time periods to really show the differences between the strength of reporting in different periods. And I'd be happy to show the full report to everybody. It's about a 40-page report. So there's a lot more methodology and everything that went into it. So we used as much data as we really possibly could to measure trends, to show trends of this population, because it really had never been done before. So we tried to just use as much data as possible. That was the sort of method to our madness. Val, do you want to add to that?
Just to add about the small number question in general, I think with this project, it might have been a little bit easier because we were looking at all AIAN individuals alone or in combination for the whole state. So it was a bit, we had larger groups that we were pulling from. So typically the small numbers issue shows up when we're looking at CMS data suppression requirements. So most of these groups had more than 11 people in them, so we were able to include them in the analysis. But yes, doing across a 7-year span is helpful.
Good question. Thank you.
Annie would like to thank you. And she wants the full report, but she's
absolutely. Yes, happy to share it. And it is also on our webpage, I believe. I will confirm that. But yes, we have a lot of information and we've happy to share it.
Okay. We have a lot of questions. So let's tackle at least a couple more and then we'll bring everybody back on. Cindy Galani has asked, she's guessing you're not able to include data from IHS clinics or facilities. Any thoughts on that?
Yeah, so that is one very important implication and limitation for this database. The COAPCD does not have IHS data. We do not have TRICARE. We do not have access to any of it. So yeah, that's just a limitation to the COAPCD. So any care that's happening at those services, we will not be able to see.
Great. So Daniel Saunders has asked, I imagine the claims data is limited to AI or AN with additional forms of health insurance. Does Colorado have a large Indian health services system that offers primary or emergency care services? And secondarily, do you have any way of estimating the proportion of AI, AN in Colorado are represented in the claims?
That's a great question. So Colorado does have a large Indian Health Services unit. So we do know that a lot of the American Indian Alaska Native population is using services through that, medical insurance. The way they're doing their claims and stuff. So we know we're missing that population. And whenever we pulled the full population of American Indian Alaska Native folks from this cohort, for the overall cohort, the entire 10 years, we pulled about a little over 65,000 unique individuals. That's about 1% of a little more than 1% of the Colorado population. It's not quite what the census collects. So we're missing about other percentage. I think the census states right now the American Indian Alaska Native population is about 1.7 to 1.9% of the population. So we were able to get, at least in the year 2024, we had about 0.7. So it is limited and it does not collect the full amount, but we're getting there. There's more, it is growing. Something I didn't get to show in this presentation either is that we're seeing a huge growth of American Indian Alaska Native folks getting commercial insurance. They're leaving Medicaid. The Medicaid population is dipping and going into commercial insurance. So we're seeing growth in different insurance payers and whatnot. And it's interesting to see in claims.
It is interesting. I think maybe one more, if it's short, we'll do two, and then we got to pull everybody on so we don't run out of time and hog the whole show, right?
Yeah.
So Kevin Langstep has asked, Kimi, can you talk more about where you get your Z codes?
Yeah, so the Z codes just come in through providers. So we're lucky if Z codes come in. They are not a required element through providers. So that's another limitation I do want to call out in terms of the analyses with those codes. We were lucky to just have any amount of Z codes. And I really hope they continue to be used, but they do come in through insurance claims, medical claims, and if providers put them in. So it's all down to providers really entering. Val, is that correct? Correct me if I'm wrong. Okay.
All right, one quick one, I think. What is your race ethnicity completeness percentage on your submission data? Which is a great question because I'd love to know myself.
Do you want me to jump into that one, Kimi?
Yes, please.
So
yeah.
It's actually a more nuanced answer. With our typical categorization, the way our algorithm is currently collected, we have about, I want to say it's between 30 to 40% unknown or unspecified. However, we've been digging into, so one of the big challenges we have is we receive race and ethnicity information across 7 different data fields. So there's race 1, race 2, and other race, and then there's ethnicity 1, ethnicity 2, other ethnicity, and then we have a Hispanic indicator. And so this has actually been an ongoing project this year. We're continuing to work on redesigning our algorithm to pull more nuanced and more granular data out of the system and also improve our ability to be a little more agile with the categorization. So with this DC project, one of the things we did was we switched from typically anybody who's 2 or more races gets categorized all into one group. And we learned that about half of the AM population in Colorado is multiracial. And so we nearly doubled the number of AIAN folks we were identifying just by pulling out that alone or in combination. And so we're working on seeing if there's a way we can apply that across all of our projects instead of in these ad hoc one-off situations. I have decreased the number of unknowns through this methodology by probably about a third. I was looking for the numbers while you were answering the other question. That's what I was looking at the side, but I couldn't find it quickly. But we are seeing great improvement when we start to look broader across those 7 fields that come in.
Thank you, ladies. With that, I'm going to go ahead and ask Charles to bring back our other presenters. Welcome back, Rong and Chris and Daniel. We have a few more minutes for questions from the audience. Is there anybody out there that had additional questions? I know that we had some questions in general from the audience after a couple of panels where you're getting your data. So what are your data sources has been a big question over here in the chat. I don't know if we want to start anywhere in particular. Anybody want to volunteer? Or I'll just call round robin.
I can start. For the analysis we did, it was all COAPCD data, and then we pulled in the American Community Survey data for context. So what was public on census website is all that we used in COAPCD claims.
Great. Rong, do you want to go next?
Sure. Our claims data comes from the Milliman sourced research data, which isn't different from the APCD data. For climate data, we pulled the daily temperature and air quality data from the EPA, and there's probably also a couple other sources that our team pulled. So I didn't deal with that part. We were only consumers of their data pool. And we also layered in SCOH data. So that is at the CBS, so the core-based statistical area. So this was, I think a common thing that people are looking at now. CBSA level community surveys. Actually, the CDC has a, it's called the Social Vulnerability Index that they developed that include about 15 or 16 different measures that they believe are showing community level vulnerabilities in the presence of catastrophes of any kind. So we use that. The common denominator, like I said, is geography.
Yeah, and for our work, the commercial prices come from the HCCI commercial claims database, which is submitted by employers for employer-sponsored plans. We also have the 100% fee-for-service Medicare data through the Virtual Research Data Center from CMS, and then some sort of crosswalk files. HCCI maintains a sort of NPI provider crosswalk file, so we can try to, if a hospital is billing under multiple provider NPIs, we can try to group those together into a single provider. And then the geography files that Ron mentioned, right, to get you to CBSA from zip code and some of the fields that are in our data.
Thank you, everyone. Were there any other follow-up questions on that from the audience? Okay. A general question for all of you, maybe thought-provoking for the audience as well. How can we make complex analytic findings more accessible to non-technical audience like patients or policymakers? How do we take it from Rong's point from here to here? How do we make action happen? How do we make it digestible? We hear predominantly probably data geeks to some degree, but I'll turn it over to whoever wants to answer that first.
I can give it a try on our stuff. It's a challenge, I would say, especially I think when we try to convey the complex interactions between climate events and health. It's almost, you can tell, you can spend like a whole day to talk about how you put the data together, and then you can spend another day to talk about the technicalities of modeling. In the end, you lose the audience. I think we actually had quite some experience, like as of late, one of which was at with the California Clean Air Day, where I was asked to present the results. So I really had to struggle. Instead of saying air quality index, it doesn't really mean much. They use a different wording, say bad air. And instead of saying that the impact is immediate, or that it takes time for heat events to play out on healthcare utilization, we would say things like, that bad air hits people right away, and then it takes more time to feel the impact of heat. I think it's probably using different words and try not to use too much terminology. I think especially when we're looking at machine learning, I mentioned the trees and so on, they're so hard to unpack. And how do you take a leap of faith and say that we're trusting the machine learning models to give us more insight? It does give far more insight than traditional statistical models. But how do you really convey that? It's a very hard thing to do. I don't really have good tricks though.
Darn.
Do we have time for me to share our experience with that? So I was grinning when you asked the question because we deal with this for every single project. But I think this really gets a lot to something that Kimi mentioned in her presentation about the importance of working with our partners who are subject matter experts. So we are the data experts, but we are not experts in every healthcare subject that we talk about or every social subject. And so we spend a lot of time with our evaluation partners in one of my partners calls them sense-making conversations. So we present, here's what we see in the data. How does that resonate with you? What are your questions? How does that reflect what you see in your everyday? And what's the story that answers the question in a way that makes sense when you combine the data with the personal experience and the subject matter expertise? And we're also kind of in a process of rethinking how we write our reports, reducing the methodology sections and really framing them around, here are the evaluation questions we had, what's the answer to the question? And we do have to include that statistical language where we talk about probability and correlation and causation and things like that, and we're careful about the language that we use for that. But if we can provide a direct, like, yes, no, or here's why it depends answer to a direct question, like the more direct we can get to interpreting the results in a way that answers their evaluation questions seems to help the most.
Thank you all. We have one last question in the audience, and I know we're over time, but Jamie Ransdorf has asked, have you considered using satellite air pollution data?
I think that is on our radar. The cost.
No pun intended.
The cost for acquiring that is at this point is still beyond our budget, but that's certainly something that would be a lot more accurate.
Well, with that, I thank you all immensely on behalf of our audience. I'm sure they're grateful too. There's been a lot of great conversation, and I hope it all continues. Thank you. With that, I'll turn it back over to Charles.
Perfect. And let me pour on some more appreciation and express NAHDO's sincere gratitude to Mary Field, star of the New Hampshire APCD, New Hampshire CHIS, for organizing and moderating this session, and to our speakers for their fascinating work and presentations, Chris, Daniel, Rong, Kimi, and Val. You're all doing the work I dreamed of doing 14 years ago when I came to my first NAHDO conference in New Orleans. So I'm only just a little bit jealous. And then finally, many thanks to this session's sponsor, Comagine Health, and all of you for attending. We appreciate you. Next up is the networking sessions. That's right. I almost said breakout sessions. Networking sessions. There are a few of them supporting Medicaid programs, data integration, multi-state collaboration, and making your data irresistible to researchers, as well as an open forum. So hope to see you over there.
Thank you, everybody.